Okay, in the last lecture we already saw that how to manage and classify the shock up to the fluid management. So if the shock is not responding to fluid management, definitely the next choice is inotrop or the vasodilators. So as I told in the last session, it is this method dopa, dobuta, adri and then death certificate. This is a wrong practice. So we have to see the new treatment modalities or new method, how to add and how to titrate inotropes. So before going to the treatment of shock, we have to know some basic pharmacology of inotrope, then only we will be able to choose the most specific or most suitable inotropes. So the common inotropes or the vasodilators that we used are adrenaline, noradrenaline, dopamine, dobutamine and vasopressin. So let us see one by one. Adrenaline usually used from a dose of 0.05 microgram per kg per minute to 0.3 microgram per kg per minute. The peculiarity of adrenaline is that from a dose of 0.05 to 0.2 microgram, from this range it will act on beta 1 and beta 2 receptors only, which means as it act on beta 1, it will increase the force of contraction, so increases the cardiac output. So which means it have an inotropic effect, whereas beta 2 act in the blood vessel which having beta 2 receptors and the effect is vasodilatation, so it will increase the perfusion. So the effect of adrenaline at a dose range of 0.05 to 0.2 is that it will act on beta 1 and beta 2, so that it will produce a increased force of contraction which will increase the cardiac output and the peripheral vasodilatation. So the increased cardiac output, the increased blood which is pushing to the periphery will be going smoothly because of this vasodilatation. Okay, that is the dose. Whereas when the dose is more than 0.2 to 0.2 microgram per kg per minute, the action beta 1 action will be preserved while beta 2 will be replaced by alpha action. So instead of vasodilatation, it will produce vasoconstriction. So that is the action of adrenaline. Now let us see what is the action of noradrenaline. Noradrenaline usually act on alpha 1. Where is alpha 1 present? Alpha 1 present in the blood vessels. So it will produce vasoconstriction and also it will act on beta 1 which have inotropic effect as I explained earlier. So in short, in noradrenaline the effect is beta 1 increases the force of contraction, alpha 1 increases the vasoconstriction which will increase the peripheral BP. So now you just keep the pharmacological actions or mechanism of action in mind, and in which scenario or at what scenario, which drug, that we will discuss in the coming discussions. So the next third drug is dopamine, and that's your favorite, but let us see how it acts. Dopamine will act on D1 receptors at a dose of 5 microgram per kg per minute, whereas it will act on beta 1 at 10 microgram per kg per minute. So beta 1 means it will increases the inotropic effect, which means force of contraction, and in 15 to 20 microgram per kg per minute dose it will act on alpha 1 which will produce vasoconstriction and increases the BP. This much clear? So dopamine action is dose dependent. Next one is dobuta. Dobuta, the main two action is on beta receptors, both beta 1 and beta 2, but very mild alpha 1 action. So the main action is beta 1 and beta 2. What beta 1 will do? As I told, increase inotropy, which means force of contraction. What beta 2 will do? It will increase or dilate the blood vessels. Okay, so main action is dobuta, main action is vasodilator and inotropic effect. So now let us see fifth drug, that is vasopressin. What is the action of vasopressin? Vasopressin is a single answer, single sure shot answer, that is vasoconstrictor. No other actions. Other actions are there like act on V1, V3, etc., but not related to CVS. Here in the context of shock, the action of vasopressin is vasoconstriction. And when to add vasopressin? Usually in the condition where we add noradrenaline, when noradrenaline's dose reaches 0.2, then in an addition to norad we will add vasopressin. That I will discuss in the coming discussions. So now you know which all are the 5 drugs and which all are the receptors on which these 5 drugs are acting. Okay, this much clear, I guess. So now the next question comes. Yeah, I know 5 inotropes or dilators now. Which one I will choose and what dose and how frequently I will be increasing the dose? This is the next question which usually come to your mind. So now let us deal with that question. Suppose a patient came to you, shock, when you examine periphery is cold and low blood pressure, which means periphery is cold means what it indicates. Periphery is cold means this is a normal vessel, this is a normal vessel, this one is a normal vessel which is constricted, that's why periphery is cold and low volume. So here you have to do one, you have to dilate this vessel. This vessel should be dilated, then only peripheral perfusion, number 1. Number 2, this peripheral cold and low volume is actually as a compensatory mechanism toward the low cardiac output or shock. So another thing we have to do is we have to increase the force of contraction. We have to increase force. So these two will be your target. We have to do these two. One is dilation, increase the force of contraction. So now which drug you will be selecting? You see, our 2 aims are, one is dilator, one is increase the force of contraction. Okay, so now let us see from here, from this group of drug, which one is a dilate. I will show a small picture. Yeah, from here you already studied the 5. Our target in a cold shock is, I will copy, one second, I will copy paste this to that side, so it will be easy for the discussion. One second. Yeah, so now we are dealing with a cold shock. The patient came to you, you found that periphery is cold and the child baby having low pulse volume, so definitely it is a cold shock and our target is to dilate the vessel and increase the force of contraction. Let us take adrenaline. Number one, let us take adrenaline have beta 1, force of contraction it can increase. So this action adrenaline can do. Now this action. Now dilatation, adrenaline can do dilatation also. So one option is adrenaline. At what dose? 0.05 to 0.2. These 2 action can be done by adrenaline. Next one, noradrenaline. Noradrenaline is a vasoconstrictor, so this action cannot be done, and inotropic effect is there, so noradrenaline is not a good choice. Now dopamine. See, dopamine dilatation, no beta 2 action, so no dilatation, so no dilatory action on dopamine, so dopamine also not a good choice. Now dobutamine, beta 1, dobutamine have beta 1 action. Our target is force of contraction, so dobutamine can increase the force of contraction. Now dobuta have dilatory effect also, beta 2 dilatation also, so both the function. So adrenaline and dobutamine can help us in a case of cold shock. But one problem is there. See, dobuta is a dilator, high dilator, forceful dilator, high vasodilator. So what it will cause? It will cause dropping of BP. So what we have to see? That's why adrenaline is the drug of choice in any case of shock with the low volume and periphery cold, which means cold shock, and that is the most common scenario that we face in our PICU. The patient usually come with the cold shock. So what is the drug of choice? Adrenaline is the drug of choice. Okay, now let us see the other scenario. Sorry. Now let us see a warm shock. Rarely you get, but we have to know the treatment, because in the last, please remember from the last video what I told regarding warm shock. Warm shock you will be getting in a patient who was admitted in your ICU for the last 3-4 days for any case of sepsis. Then so when such a baby develop shock, and if the baby is on your ICU, that shock you can easily pick up the warm shock. Otherwise it's very difficult to get a warm shock in our daily casualty duties. Okay, this much clear. Now scenario 2, warm shock. Warm shock means the blood vessel is dilated, okay, and blood vessel is dilated. Number 2, cardiac output is low. So which two action we needed in a warm shock? Cardiac output we have to increase, so inotrop we need. Inotrop means the drug which will help us to increase the force of contraction is called inotropic drugs. So inotrop, which one is the so one action we need is increase the force of contraction. Number 2, here the vessel is dilated, so we have to make it back. So we need a vasoconstrictor instead of vasodilator, because if we constrict the vessel, it will prevent the pooling of blood in the periphery, which will help us to increase the cardiac output by increasing the stroke volume. The warm shock, our aim is to increase the force of contraction and a vasoconstrictory effect. Now you see the pharmacology of the drug, and now you see which drug have these two action. Now let us check what all the actions we need. What all the actions we need by a drug in a warm shock? Here I will paste here. Paste. Okay. We need in a warm shock. Suppose it's a warm shock. We need increased force of contraction and increased vasoconstriction. See, adrenaline, force of contraction is there, but in a lower dose it's vasodilator. In higher dose only it will be vasoconstrictor. So adrenaline you can keep in your mind, okay, we can use, but dose dependent. Number 2, noradrenaline, increased force of contraction is there, so that part ho gaya. Next one, vasoconstrictor, yes, it is a good vasoconstrictor, this one also. So best drug is noradrenaline. Now let us see dopamine. Vasoconstriction is there, force of contraction is there, but what is the problem? All are, when the dose increases, one action will be gone, when the dose reduces, other action will be gone. So it is also not a good choice. Dobuta, I already told dobuta is a dilator, so this one also not good. Vasopressin, only action is vasoconstriction, so this drug also can be used. So two options are noradrenaline and vasopressin, but I told vasopressin is an added drug, additional drugs in addition to noradrenaline when the dose of noradrenaline is more than 0.2, that I will discuss later. So which are the drug of choice? Noradrenaline is the drug of choice for warm shock. So this much clear? This much clear? Okay. So now you know what, when a patient came and it is cold shock as we see in our normal PICU duty, what is the drug of choice? Start with the adrenaline 0.05 microgram per kg per minute. Then okay, you started, now you know the drug of choice. Then next what to do? Next nothing to do, just wait for 15 minutes, increase to 0.1, wait for another 15 minutes, increase to 0.2, increase to 0.3. So 15. How much? 45 minutes. This much clear? Where is the other 15 minutes? In the initial 15 minutes the management is IV fluid, so 45 plus 15 inotrop, so 45 minutes, 60 minutes, which means when the patient comes at 10 a.m., if the child is not responding, by 11 a.m. the child should be at the highest dose of adrenaline. This keep in mind. So every 15 minutes you should be checking the pulse volume, BP and the peripheral perfusion as well as urine output. Then only you will be increasing the dose. If it is not satisfactory, increase to step by step. But the baby will be on highest inotrop. This much clear? So 60 minute हो गया. 60 minute होने के बाद क्या होगा? 1 second. Okay. So 60 minute completed. Now what you will be getting? Improved, which means urine output increasing, lactate reducing, pulse volume normal, BP normalizing, or otherwise not improving. This much clear? Not improving. So now I am telling about only cold shock. Okay, please be aware that I am discussing about cold shock. How much after 60 minutes what to do with the cold shock? Please keep in mind, in our clinical setup majority of the time we usually come across with cold shock. So please be careful in this discussion. So not improving, this is the problem. If it is improving, okay, well and good, but when the child is not improving, here come the problem. Here check the BP. Not improving means periphery is still cold, urine output is low, pulse volume low. Then what to check? BP. Two options. BP is normal or little bit increased, low BP. Here BP, because according to the BP we have to add the next inotrop. If the BP is normal or high, which means vessel is constricted, that's why BP is high. So here if we dilate the vessel, more blood will be coming to periphery, it will increase the cardiac output. Okay, so here the drug of choice is dobuta, because I told dobuta is a vasodilator. But low or marginal, from where have to always keep the BP normogram, which means BP normal for each age group with you, or it should be placed in the PICU. So from there you check and you found that the BP is marginal. Suppose if we give dobuta here, the BP will again drop. So never ever try for dobuta here. Here we will add noradrenaline. So the child is now in adrenaline and it dose reached up to 0.3, still not improving and BP is low. If you add noradrenaline, it will help to increase the BP by vasoconstriction, and this increased BP will help little bit to improve the perfusion. So the perfusion is the method that we should be adopting to improve perfusion is depending upon the BP, or indirectly BP. What BP means indirectly? The vessel status, whether it is dilated or constricted. This much clear? Okay, so this much clear. So a cold shock patient, you came by 60 minutes, you reached up to adrenaline 0.3, then you check the BP. BP normal or increased. How to add dobuta? The dose of dobuta is 5 to 20. Initially start with the 5 microgram per kg per minute. Then after 15 to 20 minutes increase to 10, then 15 or even up to 20 you can go. Yeah, this much clear. So by next 1 hour child will be on maximum dose of dobuta. This much clear. If the BP is low, start with the noradrenaline, same dose of adrenaline 0.45, 0.1, 0.2, then maximum 0.2 होने से होगा. This much clear. So this also by make it on 60 next 60 minute maximum dose. Then again you recheck the child, baby improved or not. Now, if the baby improved, okay, well and good. If not improved, what to do? Not improved, it is called persistent catecholamine resistant shock. This much clear? This much clear? So after dobu or noradre, child still not improving, it is called persistent catecholamine shock. What to do in this condition? You have to do evaluate and check for any pericardial effusion, any pneumothorax, intra-abdominal pressure, and check for the etiology. What is etiology? There are, so I will discuss in the next page. So this much clear, which means after the second inotrope still not responding, it is called persistent catecholamine resistant shock, or as well as refractory shock, both are same. Bucho, clear this much? Acha. So now let us see. So persistent catecholamine shock. So what to think? First to rule out any pressure in the abdomen, thorax, which means pneumothorax. It is a condition which will reduce the cardiac output. Pericardial effusion. So what to do? Do an echo, chest X-ray, and look for the etiology treatment is adequate or not. What is that? If it is sepsis, make sure proper antibiotic at proper dose at proper site is going on. If it is a bleeding, make sure the blood transfusion is going on. If it is a congestive cardiac failure lead to cardiogenic shock, make sure child having ventilated and PRBC is adequate. How to ventilate, when to ventilate, and what is the range for PRBC transfusion, everything I will discuss in the last slide. Okay, but make sure the etiology is treating parallelly, otherwise the shock will continue. This much clear? So you know how to treat a case of cold shock. Okay, now what about warm shock? Warm shock I told you. What about warm shock? So what I mentioned is regarding cold shock. So I hope this much clear. Now let us see what we will do for a warm shock. Usually warm shock very rarely we will be getting, but if you get, start with noradrenaline, what is the dose? 0.05, then 0.1, then 0.2 what microgram per kg per minute, 0.2, and it should be almost 60 minutes. This look, BP reduced, BP normal or increased, which means here one more vasoconstrictor not needed because already BP start increasing. So stop the vasoconstrictor there. If BP is reducing and it reaching point to add vasopressin, and the dose of vasopressin is 0.0003 to 0.0012 international unit per kg per minute. This is the dose of vasopressin. This much clear? Okay. So if the BP is low, you can add vasopressin, and noradrenaline added for warm shock. BP is very high, then you can think of dobuta, no issue, but should be monitoring the BP very high. But in our clinical practice, not rarely, but we will be getting, but not common as cold shock. So actually we have to be thorough with the management of cold shock. So again I will brief this management. Okay, for cold shock, you know, drug of choice number 1 adrenaline. After 60 minutes, if not improving, dobuta or noradrenaline depending upon the BP. Warm shock, what is the drug of choice? Norad. After 60 minutes, if not improving, dobuta or vasopressin depending upon BP. This much clear? Okay. Now how you will be giving the drugs? Usually in our college we used to practice like how suppose so many into body weight into dose kitna hoga. So suppose I am telling about before that one thing. Management of both cold and warm shock. The dopa in the discussion? No, which means as per the latest guideline, dopamine is no role in shock management. When the adrenaline is not available in your unit, you can replace with the dopa with a dose of starting dose of 5 to 20. Understood? This much clear? So please note the point, very important point. Dopa have no role in the management of shock as per 2022 guideline as well as 2017 American Academy of Critical Care. This one is 2017 American Academy of Critical Care. See, the only indication of dopamine is if epinephrine not available. See the term if not available. Here see, if not available. Otherwise dopa have no role in the management of shock. This much clear? Now let us see how we will calculate the dose, because in what we following in our unit is very difficult to manage, very difficult to calculate, because it's a cumbersome calculation. Like see, body weight into suppose adrenaline I am starting with the 0.05 into 1000, so many calculation, and after each dose of suppose I started at 10 am and at 10:15 if the baby is not improving, I have to recalculate it. To avoid that, I will tell you a simple way. It is like this. For adrenaline and noradrenaline, you follow this one. What? Body weight into 0.15. Here see milligram. See this one, milligram. understood, and dilute in 50, this amount dilute in 50 ml of NS, understood. Suppose 10 kg child, 10 kg baby, 10 into 0.15, how much, plus 50, which means it comes around 1.5 ml of, sorry, 1.5 mg of adrenaline plus 50 ml of NS. How adrenaline is coming? Adrenaline is coming like in a bottle of what, 1 mg in 1 ml. So here 1.5 mg needed, which means 1.5 ampule you take plus 50 ml of NS. This one, if you keep this at 1 ml per hour, it is equivalent to what, 0.05 milligram, sorry, microgram per kg per minute, equivalent to that one. This much clear? So you make the solution and tell the sister you start at 1 ml per hour, this solution, and after 15 minutes you are seeing that baby is not improving. Our next target is what? Our next dose is 1 microgram per kg per minute after 15 minutes. So what you have to do? 1 is 0.5 microgram. So 3 ml per hour is equivalent to, if 1 ml is 0.05, 2 ml will be 0.1. Is much clear? Sorry, this is not 1.1. 1 second, I will repeat again. This much clear now. The dose is for this baby, take 1.5 mg, which means 1.5 ml, same 1.5 ml plus 50 ml of NS. Okay, this you keep in a syringe pump and this 1 ml per hour is equivalent to 0.05 microgram per kg per minute, equivalent to this much. So 2 ml per hour equal to 0.1 microgram per kg. 3 ml equivalent to कितना होगा, 0.15. 4 ml is equal to 0.2. 5 0.25. 6 ml 0.3. 0.3, 0.2, start with 0.5, then increase to 0.5, 1, 0.2, 0.3. So you keep in 1 ml per hour. Then after 15 minutes, you tell the sister change it to 2 ml per hour, or you also can change that, and then change to 4 ml per hour, which means 0.2. Then change to 0.6. That will be 3 microgram. So after each changing of, after each 15 minutes, no need to go back and calculate and write the dose. Instead, so everyone in the unit will be knowing, okay, 1 ml per hour means now the baby is getting 0.05 microgram per kg per minute. This much clear? So 1 ml, 2 ml, 4 ml, 6 ml. This is the easy way. Otherwise, you have to, after each 15 minutes, you have to go and write and calculate. Okay. So, but for Dobuta, instead of 0.15 mg is for adrenaline and noradrenaline. For Dobuta, it is 15 mg into body weight plus 50 ml of NS. This is the difference. For this is adrenaline and noradrenaline. This is Dobuta, Dopa. This much clear? This much clear? So you please take a screenshot of this one. This is for this one. Okay. This much clear? Okay. But one thing you have to keep in mind, for Dopa and Dobuta, if you made by this equation, 15 mg into body weight plus 50 ml, this 1 ml per hour in the machine will be equal to 5 microgram per kg, like that. Three ml per hour, 4 ml per hour. 1 ml is not 5.25. So this one will be sorry 1 minute, small mistake. 1 ml is equal to 2.5 microgram per kg per minute. 2 will be, what will be the 2 will be 5 microgram per kg per minute, and our dose of dobuta usually we start with 5, so 4 will be 10. So usually we can start with 4 ml per hour. We can start with 4 ml per hour of rate, so it will be 10 microgram. So next dose 15 means 5, it will be 1, it will be 2.5, 2 will be 5, 3 will be 7.5 microgram, 4 will be 10, next one 12.5, then 6 will be 15. So at 6 ml per hour होने से the baby will be getting microgram per kg per minute. So that is the easy method of adrenaline use. If you have any doubt regarding this calculation, please message me or you can ask in the group. Okay, this much clear? Okay. So our treatment of shock, that up to inotrop, you know very well how we will brief. This is adapted from septic shock management, but difference is no much difference about among the others shock also. So now we start. Initially we given fluid catecholamine. After 1 hour we selected another catecholamines. Then even after that it's not responding, then we have to change to ECMO, no other option. So only 2 inotropes are needed. Is much clear? Okay. If still not responding, ECMO, but in latest international guideline regarding the septic shock, we can try what hydrocortisone. That I will tell in the last. Hydrocortisone, whether any evidence regarding giving hydrocortisone is there or not, I will discuss in the last of this slide. So this much clear. So ho gaya. So the management of shock, first one IV fluid ho gaya, then inotropes, IV fluid first 15 minutes, inotrop, first inotrop by 60 minutes, second inotrop next 60 minutes. Still not do ECMO is in higher center, we have to think of ECMO. And associated managements. What are the associated management? Nothing. Every child should be getting oxygen, preferably non-invasive, and if severe distress, intubate the child. Next one, PRBC should be given. Next one, antibiotic for sepsis. So regarding this, I will show you what the 2020 guideline says. So now let us take oxygen. What 2000? This is 2020 international guideline. Okay. So what ventilation? This is a thing to keep in mind. No recommendation for or against, which means they are not against or they are not favor of intubation of a child with fluid refractory or vasopressor resistant shock, which means there is no definitive indication. That means you can do or you can omit intubation if the child is refractory to vasopressor and the refractory to fluid. Because in olden days there was a thought that when the child, how is the management of shock? Management of shock is like fluid. then inotrope. In the initial period, there was a thought that when the child reaches the fluid refractory stage, in this point you have to intubate the child, or some teaching was there, when you reach at inotrope resistance stage, at the time you intubate the child. But in 2020 guideline, they make clear that they are not recommending for or against, which means according to the clinical scenario you can decide. They are not recommending at this point you should intubate, or at this point they should intubate. No, they are not giving such recommendation, but according to the clinical status, you see whether the child have severe distress or severe failure. Especially in cardiogenic shock, you should be intubating the child early. So if you intubate, it will reduces the oxygen demand, it will increases the cardiac output. So intubate. First point is every child should be oxygenated, especially with the non-invasive ventilation, that is our CPAP. If possible, and whenever there is suspecting cardiogenic shock, try to intubate the child. This much clear? Now PRBC. When you will give a PRBC? Why actually before that, why we are giving PRBC? If we give the PRBC, it will increase the hemoglobin, it will increase the O2 carrying capacity, so it can tackle the shock. So blood product, why this is 2017 guideline. What it says? It says transfuse PRBC when hemoglobin is more than 7 for a stable child and more than sorry one second. In 2017 guideline, it is telling that you should be transfusing PRBC to maintain hemoglobin level more than 7 for a stable child, more than 10 for a sick sepsis child, which means for every septic child who is very sick, hemoglobin level should be more than 10 gram per deciliter. To maintain that, you should be giving a PRBC donation. Is much clear? But for a stable child, even PRBC you should be giving, you have to give only when it up to 7. But the latest guideline, what the latest guideline tell? Latest guideline tell that in a stable child, hemoglobin level should not be less than 7, which means if you found the hemoglobin report like less than 7, you should be transfusing a PRBC urgently to make it 7. But for a sick child, they are not given, unstable child, they are not given any particular threshold like older recommendation, in which they have particularly given 10. But in these studies, they have not found any particular value, which means particular value for a sick child. So whatever be the scenario, it should not be less than 7. So whenever you find a child in a shock and it's reaching 7, give a PRBC. And if you are going as per the old guideline, try to maintain more than 10 in a sick child. Okay, so I think it's better in our practical life, it's better to follow the old guideline, which means always try to keep hemoglobin more than 10. This much clear? Acha. हो गया. Then antibiotic, you know, according to the clinical scenario, you start broad spectrum, then wait for the culture. Another thing, steroid, what they are telling about steroid. So latest guideline telling that. So latest guideline is telling that what they are telling: use IV hydrocortisone for treating children with the septic shock who are stabilized by adequate fluid resuscitation and vasopressor. But you see, this is against, which means if a child is stabilized by IV fluid and IV fluid as well as vasopressor, then no need of hydrocortisone. Hydrocortisone were if the child is not improving by what? The child is not improving by, I told the management, by all this method, like So we treated up, we reach up to this, still not improving, then you can try hydrocortisone in a septic shock. This is by the recommendation 2020 International Septic Shock Guideline. This much clear. So that is the management of sepsis. And when we will stop the management of sepsis treatment, shock treatment, the therapeutic endpoints are that heart rate should be normal, CRT will be normal, urine output will be 1, normal blood pressure, normal mental status, improving serum lactate and metabolic acidosis. So this much endpoint the baby should be attaining to reduce the inotrope. And next question, how should I stop the inotrope? You have to see the child is very sick and I was very sick, and then it's better to reduce over every 3 hourly, reduce the dose, then gradually, better to stop gradually. That is the method of treatment, stoppage of inotropes. So I hope this much clear. If you have any doubt, you can just message in our group, so we will discuss the doubt part.